lecture, the immune system. Now, wonderful news, this is going to be a little bit shorter than one of your typical Archer system lectures because the immune system really piggybacks on your previous lecture, the hematological system. When we talked about hematology, we looked at the three big types of blood cells, those red blood cells, those platelets, and I told you your white blood cells, we were going to get to that in the immune system. So today it's time to dive into that and look at how white blood cells form the fundamental purpose of that immune system to fight infection. So let's first jump into the anatomy and physiology and see just how they do it. As you learned in your hematology lecture, all of those blood cells are produced in the bone marrow. So those red blood cells or erythrocytes, those are carrying oxygen. You see next your platelets or your thrombocytes helping our blood clot, forming those platelet plugs. And then you see all of your white blood cells. So we can really categorize those leukocytes or white blood cells into two broad groups. We have your granulocytes and your agranulocytes. And when you look at the granulocytes under a microscope, you're going to see that they almost look like they are coated in a layer of sand. They're grainy. They have these granules. That's why we call them granulocytes. Those are all the types of white blood cells ending in that "phil." So we've got our neutrophils, eosinophils, and basophils. Now, neutrophils are our most common type of granulocyte. They are phagocytic, so they're able to eat bacteria and secrete toxins that fight off all pathogens. All right, so when you think white blood cells, when you're just thinking in general, you are probably thinking of a neutrophil. It's eating up that bacteria, it's fighting off all of those pathogens. When we talk about a client who is immunocompromised, they don't have an adequate immune system, oftentimes we specifically look at how many neutrophils they have left. We might run a specific lab test called an absolute neutrophil count or an ANC. We need to have enough neutrophils to be able to fight off bacteria. Your next granulocyte is that eosinophil. Now, when I think of an eosinophil, two things come to mind: parasites and allergies. They are going to be really elevated in the case of an allergic reaction when we're getting all of that histamine release. I know I have some seasonal allergies when there's a bunch of pollen, my eyes itch, my nose runs, and my eosinophils are elevated. They're also what elevates in the case of a parasitic infection. So those are the two big trigger words for eosinophil that you're going to want to remember. Our last granulocyte is that basophil. So this cell is going to release histamine, all right? That's going to contribute to our inflammatory response. So similar to what I was just talking about with allergies, when we have an inflammatory reaction occurring in our body, whether it is pathologic or part of a normal immune response, our basophils are going to be releasing that histamine. Now, next, you see the agranulocytes, okay? So remember, A means without. Anytime you see that prefix, we're doing without something. Agranulocytes without those granules. So these are your monocytes and lymphocytes. And then lymphocytes can differentiate into a few different types of cells. You've probably heard of these guys before: the T cells, B cells, and then we have those memory cells. So looking at their specific functions, let's look at those lymphocytes first that can turn into T, B, or memory. These are part of what we call an adaptive immune response. We'll get into the nitty-gritty of that a little bit later, but it's our body learning different pathogens and organisms that it should be fighting against. So let's say that when I was 5, I got the chicken pox, and my body was exposed to that virus and all those viral particles. My body then learned, okay, this is no fun. We're going to get rid of this foreign invader. And it makes sure to remember what that virus looks like for next time. So the next time I go to work and take care of a kiddo that has the chicken pox, I should be protected. That's what we mean by this adaptive immune response. We're constantly adapting and evolving as we learn more foreign invaders and organisms that our body's going to help us protect against. So let's look at these specific cells. Those T cells coordinate an attack to directly kill the pathogens. All right, you might hear them called killer T cells. They are going to launch the attack. They're the soldiers that kill that infectious organism or foreign invader. The B cells are the cells that produce antibodies. Right, we're going to look at antibodies here in just a moment. Lastly, the memory cells are going to be the cells that hang around after the invader is long gone, so that if they ever come back, we know exactly what we look like. Our B cells will make antibodies against them, and our T cells will go attack them. All right, last agranulocyte is the monocyte. Now, when monocytes become activated, we call them macrophages. They are big, giant cells that go eat up other cells marked as foreign. If a foreign cell has an antigen on its surface, and our body knows that we want to destroy it, it's going to activate some monocytes. Those monocytes will turn into macrophages and eat up those foreign antigen-presenting cells. So what are these antigens and antibodies? I know that terminology sounds a little confusing, but it's actually quite simple. An antigen is just a protein marker on the outside of a cell. All right, so you see all those orange little spikes going off of that cell? This is an antigen presenting cell. It is marking itself. This antigen is saying, hey, this is who I am. It's like a flag, okay? It helps the body know what's self and what's other. What do I attack and what belongs here? What should I leave alone, right? Now, antibodies are like the key. They are going to lock right onto that antigen and attack the cell. Antibodies made by our B cells are designed specifically for one antigen. So, if I was exposed to that chickenpox virus when I was 5, I've got antigens for the chickenpox. Oh my gosh, I'm starting to get sick. Now, my B cells are going to start making these antibodies to go latch on to that antigen and mark the cell for destruction. Let's eat this cell up. Let's get this foreign invader out of here. Now my memory cells are going to keep making those antibodies. So if the chickenpox ever comes back, I've got these little keys floating around looking for a match. And if they latch on to that antigen, they're going to sound the alarm. Hey, the chickenpox is here. We need to get rid of it. So we've heard a lot of talk lately about people being positive for antibodies, this and that. That's all an antibody is. It's monitoring, looking for that foreign cell, forms a perfect fit and tells our body, hey, let's go destroy this. So what we've just been talking about is an example of that active immunity. I get sick, I form those antibodies, my body fights it off, and the next time that I'm exposed to that organism, I've already got the antibodies. I might feel a little under the weather, but in most cases, my body's going to be able to fight that organism off before I'm ever really ill. We obtain active immunity through that adaptive immune response when we're exposed to new organisms, whether it's actually getting sick or through a vaccination that stimulates that active immune response. The other type of immunity is when we receive those antibodies passively. So there's no foreign substance, there's no antigen stimulating the production of antibodies. We just get the antibodies. This is great, but the immunity only lasts as long as the antibodies are present because our body hasn't been stimulated to make any of its own antibody. We're just kind of freeloading and taking some antibodies from somewhere else. This could be from mother to fetus, from a nursing mother to a breastfeeding infant, and lastly, through the administration of antibodies, such as administering immune globulins. Next up, let's talk about those different pharmacologic agents specific to the immune system. These are mainly going to be things that help us achieve that fundamental purpose of the immune system, fight off infection. And the different ages will be broken down depending on the different type of infection we're trying to fight off. We first have our antivirals. Now, I'm just going to present these as a large class. You don't need to get into the nitty gritty on each one. That's outside of what you're going to be asked about on the NCLEX. They're going to end in vir, acyclovir, ganciclovir, remdesivir. That's how you're going to know you're working with an antiviral. These are going to help kill those viral particles that are making us sick, that are infecting us, so that hopefully we are well soon. Next, if it's a fungi that's making us ill, we can use an antifungal. Meconazole, fluconazole. As you can see, they end in zol. That's going to tell you you're working with an antifungal. Similar concept. I don't need you to get into the nitty-gritty. I need you to recognize those last 4 letters, know you're dealing with an antifungal. It's going to go and try to kill that fungi that's making us ill, again, so that we can get well. A specific antifungal that I do see coming up a lot is that nystatin. Nystatin, notable because the name is different. It looks different than meconazole, fluconazole. And we use it specifically as a topical cream or powder, often to treat a fungal infection that's on the skin or one that's in the mouth. Sometimes we can get an overgrowth of fungi in the mouth, specifically coating the tongue. We call that oral thrush. The tongue looks all white and coated. Yuck. Nystatin is commonly, we're going to prescribe it in like a little swish and spit liquid, very common to be used for that specific fungal infection. Next, if it's a bacteria causing the problem, of course, we're going to use an antibiotic. And as you guys know, there are hundreds, if not thousands, of antibiotics out there on the market. No nurse would ever be expected to know them all. Instead, we're going to talk about some of the major classes and those big nursing considerations that you can expect to see on your exam. All right, first type of antibiotic is called an aminoglycoside. Funny name, you'll probably just recognize gentamicin, neomycin, vancomycin. As you can see, they all end in that mycin. That's how you're going to know you're working with an aminoglycoside antibiotic. We primarily use them to treat gram-negative infections. How are they going to work? They are going to go inhibit those bacteria from being able to produce proteins so that the bacteria die and stop making you sick. What do you need to watch out for with aminoglycosides? Tinnitus, ringing in the ears. They can be ototoxic, damaging to the ears. So with aminoglycoside, I'm going to watch out for that. Now, one of our big heavy hitters, vancomycin. Specifically, it is a glycopeptide antibiotic. That's way more than you need to know. What I want you to know is that vancomycin is broad spectrum, so it's going to kill lots of bacteria. That's good if you're really sick and we want to wipe all of those bad guys out. That's bad on your gut though, because we've got a lot of good healthy bacteria helping us digest food in our gut, and vancomycin's going to kill them. All right, so I want you to know vancomycin specifically for the indication of sepsis. When our client gets really sick and an infection makes its way all the way into the bloodstream. Vancomycin, broad spectrum, gonna kill all that bacteria. Now, again, aminoglycoside, I'm worried about the ears. Ototoxicity, watch out for that tinnitus. Now I'm also worried about the kidneys. It is nephrotoxic, dangerous to the nephrons, the kidneys. So keep an eye on those renal labs, BUN and creatinine. If they start to bump, I might consider if they really need to be on that vancomycin. Lastly, vancomycin can cause something called red man syndrome if it's administered too quickly. This is almost like a pseudo allergy where the client breaks out in hives. They get red, 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 like stop sign red, not just like a little rash. They turn super red. They feel hot, itchy hives. Seems like a major allergic reaction. It's just from the vancomycin being administered too quickly. We want to give this slow, minimum, I'm talking minimum, over an hour. I've seen it, I've personally given it over 4 hours. We are really going to be taking it slow when we give the vancomycin. I also prefer to give it in a central line because it's really irritating to those veins. If we give it in a small little 24 gauge in the thumb, it's going to cause phlebitis, that inflammation, pain. You got to let your client know, guys, hey, this might burn a little bit. Keep an eye on that IV site. It's definitely not going to be comfortable. And if you need to, slow it down even further. All right, so this is a nasty drug, not fun when you have to give it, but if your client is septic, this is the antibiotic you need to go to. Next, we have our fluoroquinolones. Now, funny name again, anytime you're dealing with a fluoroquinolone, you're going to see a very specific part of the drug name. Fluoxetine, levofloxacin, ciprofloxacin. So you don't need to memorize them all. You're definitely going to know you're dealing with a fluoroquinolone antibiotic. It's got that fluoxetine. Now, these are indicated for all types of infections, going to be really common when we have either a urinary tract or respiratory tract infection, but there's no specific limitation. They can be used for infections throughout the body. They're going to kill DNA of bacteria, stop them from replicating so that those bacteria die and stop making you sick. 3 big nursing considerations for these drugs. They can prolong the QT interval, so we don't want to be on them for a prolonged period of time. If somebody is, let's monitor that EKG to make sure the QT interval doesn't get too long. Because remember what can happen if it does? Torsades. Definitely not what we want to do, so keep an eye on that QT. Second, there's a black box warning of potential tendinitis and tendon rupture. All right, this is more prevalent in pediatrics, but the incidence is still so low that it's often prescribed. I do find that this is a potential adverse reaction that the NCLEX likes to test you on, though. So when you see those fluoxetine, levofloxacin, ciprofloxacin, think tendon rupture. All right, lastly, they are going to decrease how effective phenytoin is. That long-term maintenance drug to decrease seizures doesn't play nice with the fluoroquinolones. If your client is dependent on phenytoin for controlling seizures, we need to pick a different antibiotic. Last group of antibiotics to mention here, I know you've heard of them. The very first antibiotics to ever be discovered are penicillins. Names are going to play really nice here. Amoxicillin, ampicillin, penicillin. When you see that cillin, you know you're dealing with a penicillin antibiotic. They're used for all sorts of bacterial infections throughout your body. Once again, they're going to go act on that bacteria to kill it, stop the bacteria from being able to reproduce so that it goes away and you feel better. Now, just like we've been talking about for a few of these, they are rough on the kidneys. So keep an eye on that BUN and creatinine. As a general rule of thumb, we want to watch our renal function while our client's on antibiotics. For penicillins, it's also important to monitor for a rash. We have many clients who can be allergic to penicillins, so we want to be on the lookout for that, especially if it's the first time they're receiving one of these drugs. The next group of medications acting in the immune system do pretty much the opposite of those anti-infectives we just covered. They actually suppress the immune system. Immunosuppressants such as tacrolimus, sirolimus are going to act on the immune system to decrease its responsiveness. So neutrophils going down, basophils going down, eosinophils, monocytes, lymphocytes, they are not going to be as active. Now, you might be wondering why on earth we would try to get somebody's immune system to be less responsive. That's not usually what we're going for. There are two major times where immunosuppressants are used. When we have an autoimmune disorder, meaning the body is attacking its own self and we're trying to turn off an overactive immune system, or when a client has received an organ transplant. We have a foreign object now in the body that naturally the immune system will want to attack. But we can't let it, otherwise they'll reject that organ. So transplant recipients are going to chronically be on one of these immunosuppressants. I personally have worked with a lot of heart transplants, and Tacro or tacrolimus is usually the immunosuppressant of choice that at least I have personally seen. A few things you need to know about these drugs. Obviously, the client's going to be more susceptible to infections. If we're dialing down their immune system and they come across some bacteria, I might be able to fight it off with my immune system, but they probably won't be able to. So they're going to be at really high risk for infections that most people wouldn't be susceptible to. For that reason, they should talk to their healthcare provider before they receive vaccinations. We'll talk about vaccinations here shortly, but as you probably know, vaccines activate our immune system so that we can learn to fight off a virus. Now, you and I, our vaccines are going to stimulate an immune response and we're going to be just fine. But for a client on an immunosuppressant, their immune system may not be able to handle that vaccine. It's not going to respond normally. That's not the case for all vaccines and all people, which is why it's really important that they get individualized advice from their healthcare provider before making any decisions. Also, no grapefruit. We know grapefruit interacts with many medications. These immunosuppressants are one of them. They cannot have grapefruits after they are on that immunosuppressant. And unfortunately, it does come with a lot of GI upset. Nausea, vomiting, diarrhea, anorexia, major side effects of these immunosuppressants. So those vaccinations, I'm including this here in immune pharmacology since it's a medication we receive to hopefully help stimulate our immune system. This is where an inactivated or attenuated portion of a virus is introduced to the body, and the body then responds with our active immunity. We're going to learn, oh, hey, that's what that antigen for the flu looks like. I'm going to make some antibodies. And it's just a really small little inactivated part of the flu, so it doesn't actually make us sick, but our body forms those antibodies. So when the flu comes around in December, like it always does, I'm already going to have some antibodies ready to go and fight it off. So two kind of categories that vaccines fall into. We've got our inactivated vaccines. So that's a killed version of the germ. It's not going to cause as big of an immunity boost or protection, not quite as strong. So you may need boosters over time. It may take a series of vaccines. Versus our live attenuated vaccines are just weakened portions of that germ that causes the disease. So they're going to cause a bigger immune boost. These are the ones that our clients on an immunosuppressant or who are immunosuppressed want to consult with their healthcare provider about. Okay, so vaccines help us produce antibodies. We get some active immunity. Less medication here, actually administering antibodies for some passive immunity. Immune globulins. These are manufactured antibodies delivered directly to the client. There are tons and tons out there. All sorts of meds you're not going to be tested about. The two that I most often see are IVIG, IV immune globulin, or that RhoGAM. We're going to go over RhoGAM in depth in maternity, so kind of tuck that away for now. We administer these antibodies to a client who's immunodeficient, has an autoimmune disorder, and needs some passive immunity through the administration of these antibodies. Now, specifically when we're giving them IV, such in that IVIG infusion, there is a very high risk for a sensitivity reaction, especially the first time that they receive this med. So we are going to go low and slow. We start it just very, very, very slowly and then turn it up a little bit, turn it up a little bit. We titrate it on slowly. It's also pretty common that we pre-medicate these clients with acetaminophen and diphenhydramine, since they can cause that very uncomfortable kind of response. Now, not always, just something that you're likely to see if you're in a setting where you give IVIG. I'm not gonna lie, this is not one of my favorite drugs to give because you are constantly in the room titrating that drip up and down and making sure it's in the exact right rate. It's not one that you can just set it and walk away from, so it does take a lot of time to administer. Excellent. Time now to move into the different disorders of the immune system. These are also going to fall in two main buckets. Infections, when we activate that inflammation and immunity because of a pathogen present in the immune system, and when we have an autoimmune disease, when the immune system is overactive, mistakenly turned on, and attacking our own body. So naturally, first things first, we have infections. When there is invasion from a foreign organism, it makes its way into our body, our immune system reacts. Now, the different ways we can categorize infections are communicable, non-communicable, and then healthcare acquired. So most of the infections we think about are communicable. They can be communicated or transmitted, spread about from person to person. This is your flu, your respiratory viruses, your skin infections like strep and staph, mumps and measles, all of those that we talk about that can be transmitted. When they are non-communicable, they're infections that aren't able to be passed from person to person. So think about when we have an infection inside our heart, like endocarditis. If you have endocarditis and I go and touch you, I'm not going to get endocarditis. Still an infection, but not communicable. Lastly, we have the healthcare acquired, meaning that the client picked them up in the healthcare environment. The big three that we talk about throughout our lectures are CAUTIs, CLASBs, and SSIs. CAUTI stands for a catheter-acquired urinary tract infection. Client gets a Foley catheter, and whoops, we got some bacteria in there, introduced it into their urinary tract and caused an infection. We talk about this a lot in our renal lecture. Next, we could have a CLASB, a central line associated bloodstream infection. Ooh, these are super dangerous, not what you want to be dealing with. This can occur either upon insertion, doing a dressing change, or just routine care of a central venous catheter if you're not extremely diligent about sterile and clean technique. Remember, we use sterile technique for insertion and dressing changes, and we use clean technique anytime we touch that central line. Because if it gets into the bloodstream, that is really, really dangerous. Lastly, an SSI stands for a surgical site infection. So maybe the client had a CABG. Now they have a big sternotomy, and we don't do proper wound care, and that surgical site gets infected. Any of those, they're the hospital's fault. Hospital is not going to get reimbursed for them. And even more importantly, we've introduced an infection that our client didn't need to have. That's prolonging their hospital stay and causing suffering on their part. We're going to have to use antibiotics and things that we otherwise wouldn't have. So we need to do our due diligence in preventing them. Now, for those communicable diseases, those that can be transmitted, you need to be aware of those transmission-based precautions. This is reviewed in depth in that safety and infection control lecture. As a quick recap, you have your contact precautions for diseases that can be transmitted via contact from person to person. So these are things like MRSA, BRE, conjunctivitis, It is infectious agents that when I touch you, direct contact with that client, if they have it, I can get it. Now, for those pathogens that are spread through close contact with respiratory secretions, so we get droplets of respiratory secretions. If I'm right here up in your face and you cough in my face, those droplets can get in my mucous membranes and make me sick. All right, so this is your flu, your rhino, your adeno, strep, rubella, diphtheria. These are your precautions that you need to take. Droplet precautions for spread of a pathogen through respiratory droplets. Last but not least, for those special pathogens that can remain alive in the air for long periods of time, we need those airborne precautions. Pathogens that can do this are things like TB, rubeola, that's your measles, varicella virus, the chickenpox, varicella zoster, that's that shingles virus, SARS, and smallpox. They remain alive in the air for a long time, at least 10 minutes, which means we need a mask that can actually deal with special air handling. So it's an N95 mask or higher. Okay, now all of these precautions are reviewed super thoroughly in that infection control and prevention. We talk about how you need to implement airborne, droplet, and contact. Obviously, a big part of your immune system. We want to stop ourselves from getting these infections, especially as healthcare providers, because if our immune system doesn't have to become activated, I would rather it not. So let's break down now some different infections by system. Now, all of these infections are reviewed in their respective system by system lectures. So for more in-depth info about them, make sure to refer back to each of these lectures. But as a quick synopsis, look how every single area of the body can become infected with a pathogen. And then our immune system becomes active. In the cardiovascular system, if we get an infection in the wall of the heart, myocarditis, an infection in those valves inside the heart, that can be really dangerous. That's usually a bacterial infection, endocarditis. And those bacteria, remember, can clog up and end up causing a bacterial emboli. Ooh, scary. Really, really scary when we get infections in the cardiovascular system. Of course, respiratory, one of the most common systems affected by pathogens, especially those viral infections. Adeno, rhino, RSV, flu. We get all sorts of viral infections, especially in the wintertime. Remember, when infections get down in the alveoli, we can have pneumonia. It can be caused by bacterial invaders or viral invaders. Now let's talk neuro. What about when an infection gets up in the brain? Encephalitis, or around the meninges, meningitis. Remember, we have bacterial and viral meningitis. Bonus points if you remember, which one is more dangerous? Bacterial meningitis. That one requires droplet precautions, right? Viral meningitis is a little less scary. We just have to do contact for viral meningitis. Now, in the GI tract, obviously, stomach bug, right? We can have gastroenteritis. There are tons of bacteria, viruses, and fungi, parasites that can get into your belly. And then your immune system becomes activated. We talked about a UTI in the renal system. What if that infection gets all the way up into the kidneys? Pyelonephritis. In the reproductive system, you have all your STDs. Looking at the bones, when infections get into those bones, we have osteomyelitis. And then, of course, on your skin, you know that skin integumentary lecture is coming up super long because it's got so many different infectious diseases that can get onto the skin. Staph, cellulitis, impetigo, MRSA. Now, those are just bacterial. We have yeast infections of the skin. Those are our candida infections. We have fungal infections of the skin. Those are tinea infections. So, when you think about how to treat all of these infections, go back to that infectious disease pharmacology. Think about the infectious agent. If it's a bacteria, we'll use an antibiotic. If it is a fungal, we'll use an antifungal. So example, for your fungal infections, your tinnias, am I going to give an antibiotic like ampicillin? No, I'm going to give an antifungal, maybe like fluconazole or nystatin. For a lot of those skin infections, we might use an antifungal cream, a topical medication. And we'll talk about all of those in that integumentary lecture. So again, I know this is a broad breakdown. This really shows you how infectious disease and the immune system relates back to every system of your body, because everywhere can get infected. And unfortunately for us, that includes a systemic infection in the bloodstream. When that infectious particle makes its way all the way into the blood and our body reacts, we get a systemic inflammatory reaction known as sepsis. Here's how it works. Infection gets in the bloodstream. Immune system responds. High alert, invader in the bloodstream. We are nervous about this. What it does, though, is honestly not super helpful. First, it increases the capillary membrane permeability. So all of those cells in the wall of the blood vessel that are usually nice and tight, they get wide. Okay, this is no bueno because now fluid can leak out of the blood vessels. It used to stay nice and tightly packed inside of there. Now we've opened up the gates, fluid just leaks right out of the blood vessels. All right, I bet you already know where this is going. With less volume, we now have less pressure, lower blood pressure, hypotension. We're not getting good perfusion out to the tissues. Bummer. Now, the second thing that happens when we get this systemic inflammatory response is vasodilation. The blood vessels get bigger in response to this infection. What's the second way that we can lower our blood pressure? Bigger vessel, more space. When that fluid has more space, the pressure goes down. So the immune system's response to this systemic inflammatory reaction is to do the two things that lower our blood pressure. Fluid leaks out, less volume, less pressure, and vasodilate, more room, less pressure. So this client's blood pressure tanks. It just goes down, 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 down. It's got tons of space and not a lot of volume. And what does that lead to? An inability to perfuse the tissues. The blood pressure is literally not high enough to carry blood out to the tissues, which means the tissues are not getting oxygen. And when there is a deficit of oxygen at the cellular level, what do we have, archer nurses? Shock. Deficit of oxygen at the cellular level, shock. So you've probably heard septic shock, septic shock. It's a type of distributive shock. The cardiovascular system is unable to distribute blood to the tissues. It is unable to perfuse the vital organs. Nothing's getting oxygen. Shock. Okay, what's this client going to look like? We have a little mnemonic here. This is what we use to kind of educate clients on who is shocky, who looks like they might be in shock. So this might be some of the first things you see. They are shivery, cold, even though they have a fever. Extreme pain or discomfort. They are pale, discolored skin, pallor. They're sleepy, fatigued, very difficult to arouse. The eye is, I feel like I might die. Sense of impending doom. They feel that way because they're hypoxic. When the brain doesn't get oxygen, it makes you feel like you might die. S, short of breath. Lungs not getting oxygen. Dyspnea, feel like they can't get a good breath. So those are kind of your general assessment findings. Now, getting more clinical here. What are we going to see on these clients' labs? All right, let's draw an ABG. What do we think we're going to be seeing? Metabolic acidosis, right? The tissues are not getting enough oxygen. What happens when our cells don't have oxygen? Remember, back from our shock lecture, they've got two choices: die, switch to anaerobic metabolism. We're quite resilient, so our cells aren't just going to give up and die. They're going to switch to anaerobic metabolism, making energy without oxygen. Usually they need that oxygen for aerobic metabolism. They don't got it. They switch into that anaerobic metabolism, and a byproduct is lactic acid. So I see a bump in lactic acid, their lactic goes up, and that acid causes a metabolic acidosis. pH going down, lactic acid going up. All right, anytime I see a lactate level high, I am thinking shock. I don't know for sure what's going on and why my client has bumped a lactate, but I know that means their cells are not getting oxygen. I've got a big problem on my hands. Next, let's take a look at their CBC. Red blood cells, platelets, all that's probably going to be fine. We talked about that in your hematology. But what's going to be happening here to my white blood cell count? Sky high. When I have an infection, white blood cells go up in a healthy body. As long as my client's not immunocompromised, they make more white blood cells to fight off the infection. We call that leukocytosis. Leukocytosis. More white blood cells, more neutrophils, eosinophils, monocytes, lymphocytes. Let's go fight off that bacteria. We see it go up. Okay, let's take a look at vital signs. What's going on here? We know they're febrile. We know their blood pressure is in the toilet. Why is their blood pressure so low? Vasodilation, increased capillary membrane permeability. Fluid is leaking out of that blood vessel. Less fluid, less volume, less pressure. Big blood vessel, vasodilation, less pressure. Hypotension. Why is my heart rate going up? Tachycardia to compensate. The body is trying to make up for lost cardiac output. It knows it's not perfusing the vital organs. It's trying to do the best it can by elevating the heart rate. It's not enough. We're tachycardic, hypotensive, and of course, we are febrile. So what do you want to do, Archer nurses? Think back to your immune system pharmacology. We've got a bacterial infection in the bloodstream, systemic inflammatory response. I want to get some antibiotics in them ASAP. Let's go fight off that bacteria. Root of the problem, remember, always go back to the cause. What is causing this client's problem is an infection. I need to fight off this infectious disease. Before I can get those IV antibiotics started, I need to get a blood culture. My priority action when they come in with suspected sepsis is blood culture. A blood culture is a specific test where I'm going to draw some blood, basically send it off to the lab. They're going to put it in a little petri dish and see what grows. So they're trying to figure out what bacteria is growing inside your client. If it grows in the lab in the petri dish, that's what we know is growing in your client. That's your blood culture. We have to get that first because if I give my vancomycin and then draw my blood culture, it's not going to be accurate. I've contaminated the blood with that vancomycin, so the bacteria is not going to grow. That's why we do blood culture first, see what's growing, get those antibiotics started. Now, let me be clear. You do not wait for the blood culture to come back until you start those antibiotics. No. We're starting those IV antibiotics within 1 hour is our goal. Really, within 30 minutes is even better. The faster they get those antibiotics in, the better chance they have. So I just have to draw that blood culture and then I can immediately hook up my antibiotics. And this is usually how it goes in a team environment working in the emergency department. Someone comes in, we think it might be sepsis. All right, I'll say, okay, I'm going to draw the culture. I'm going to start an IV, draw blood right off of that. My friend over here is mixing up the vancomycin. She's getting the antibiotic ready. I'm going to hand the labs off to my other friend, Susie. She's going to take them to the lab. And then my other friend, she finished mixing that vancomycin. She's going to hand it to me. I'm going to hook it up and we're going to get it started. Multiple people are going to be in the room making this happen, okay? I know on the NCLEX, it's just you and the client on the screen. I just wanted to tell you in real life, that's kind of how it goes down. Your NCLEX priority, get that culture, start those antibiotics. Okay, are you now just ready to walk away? They're good to go? You finished your priority? Their blood pressure is still like 60/30, heart rate in the 160s. No, you are going to need to address your ABCs, all right? They should have an airway, they should be breathing, but this is a client that has a circulation problem. We need to give them fluid. We need to fluid resuscitate this client. Remember, they've got that increased capillary membrane permeability. Fluid is just leaking out of those vessels. Less volume, less pressure. Let's give them some volume back so we can get that pressure up. So as a general rule of thumb, we are going to give a fluid bolus, see if they get better. Then we're going to give another fluid bolus and see if they get better. Then we're going to give another fluid bolus and see if they get better. We are going to keep giving them fluid until, one, they get better, yay, or two, they are fluid overloaded. How do I know they're fluid overloaded? I start to hear crackles. I start to hear that S3 heart sound. When their lungs are wet, when I hear that S3 heart sound, I'm like, okay, they are full of fluid. I've given them as much fluid as possible. Do you think this client might still be hypotensive though? I think they might be. Remember, there are two things going on in the pathophysiology. Not only is they have a capillary membrane permeability that's increased with fluid leaking out of the vessels, they also have massive vasodilation. So think about your blood vessels like should be the size of a straw, and they have vasodilated to be the size of a fire hydrant. No matter how much water you put in there, is it going to come out of that fire hydrant very quickly? No. We are not going to be able to fluid resuscitate this client to a normal blood pressure. Most of the times, we're going to have to resort to those vasopressors. We need some vasoconstriction to make those vessels smaller and get that blood pressure up. All right, Archer nurses, write on your scrap paper, call it out to me on your screen. What are the names of some vasopressors? What might you want to give your client right now? You fluid resuscitated them. They're starting to have some crackles and fluid overload, but they're still hypotensive. Now they're 80/40. What do you want to give them? Some epinephrine? Some norepinephrine? Some dopamine? All great answers, Archer nurses. Those are things that are going to vasoconstrict, make that vessel smaller so that we can get that blood pressure up. So that's what we have to say about infections, where the immune system is activated and fights off that invader appropriately. Our last group of immune system disorders, however, don't quite work like that. In an autoimmune disorder, the immune system turns on itself and ends up attacking the body. Each of these are reviewed in their appropriate system-by-system lecture, but we will take a brief look at the variety of ways that the immune system can turn on the body. First, we have lupus, systemic lupus erythematosus, abbreviated SLE, is the most common type of lupus. In this autoimmune disorder, the immune system attacks pretty much the whole body. All right, the joints, skin, brain, lungs, kidneys, and even the blood vessels can all be sites of attack. So this causes widespread inflammation and tissue damage. You're going to see a client who is fatigued. They are febrile, both of these due to the inflammation. Their joints are swollen, red, and painful. They might have rashes when their skin is attacked. It tends to come in flare-ups where the disease is really prominent and then go into remissions. Unfortunately, like you'll see with most of our autoimmune diseases, we don't have a definitive cure. Instead, we manage their symptoms. This might be a client who's a candidate for immunosuppressants, right? Calm down, immune system, stop overreacting. We also might give steroids to help with the inflammation. And it has been approved to administer the malarial medication hydroxychloroquine. Next, a few autoimmune disorders of the nervous system. You'll remember multiple sclerosis is where we have an immune system attacking the myelin sheath around those neurons. Causes a lot of inflammation in the central nervous system and really impairs the body's ability to communicate and effectively send those impulses down the axons of the nervous system. We also see myasthenia gravis, where the communication between the nerves and muscles is destroyed by the immune system. So this is all the way at the end of the axon at that neuronal junction where the nerve is trying to tell the muscle what to do. The immune system attacks and stops that from happening. If you remember, the hallmark sign was that ptosis, drooping eyelid, because the nerve couldn't tell the muscle what to do there. And we diagnose it with that administration of endophronium to see if it makes it better. We call that the Tensilon test. Last autoimmune disorder that we reviewed in your neuro lecture is Guillain-Barré syndrome. This is when the immune system attacks the myelin sheath of the peripheral nerves. So multiple sclerosis, we had demyelination in the CNS. Now in Guillain-Barré, we have demyelination in the PNS. And it causes that hallmark ascending weakness and paralysis. So of course, we're worried about the respiratory status. Now in your musculoskeletal lecture, you will learn about rheumatoid arthritis, where we have the immune system attacking the joints. It's actually destroying the connective tissue and synovial membrane of the joints. So we get a lot of weakness, dislocation, and deformity of those joints. They're red and swollen and tender. Like you've seen with a lot of these autoimmune diseases, come in periods of flare-ups where they get really bad, and then periods where they go into a little bit more remission. We notice that those flare-ups tend to coincide with periods of stress and fatigue where possibly the immune system is already overwhelmed. In your integumentary lecture, you'll learn about the autoimmune disorder psoriasis. This is an autoimmune T-cell mediated inflammatory disease. So those T cells, those killer T cells of the immune system, they start attacking the epidermis and the dermis. That causes thickening. They get these scaly, erythematous pruritic plaques. So pruritus is itching, itchy plaques like you see in this photo down here. Again, we don't have very good treatment options. As you've seen with most of these autoimmune disorders, it's hard to fix the root cause of the issue when the cause is your own immune system. Now, in endocrine, we have several different autoimmune diseases. Graves' disease is autoimmune attacking the thyroid. Immune system starts attacking the thyroid dysfunctions, and we get high levels of that thyroid hormone. Too much metabolism. The hallmark sign there was that exophthalmos, right? And then one of our most common, type 1 diabetes, an autoimmune disease where the immune system eats away and destroys those beta islets of Langerhans in the pancreas. Those beta cells are what makes insulin. When the immune system kills them, the pancreas can no longer make insulin. That's what causes all the assessment findings in type 1 diabetes. So the immune system is pretty great when it's on our side. If I get an infection with influenza, I'm going to be really excited that I have antibodies from my vaccination to go fight off that flu. Or if I'm exposed to a bacterial infection that I developed active immunity for earlier in life and I've still got some memory B cells, some antibodies hanging around, I'm not going to get very sick, and that's great. But when the immune system turns on itself, as you can see, it can really cause problems in every system of the body, from the immune system attacking the myelin sheath in the central nervous system, causing multiple sclerosis, all the way to the immune system attacking the pancreas and causing type 1 diabetes. Don't forget that every single one of these autoimmune disorders are reviewed in the respective system by system lecture. Thanks for reviewing the immune system with me, Archer nurses. I hope you learned a little bit of something about how the body fights infection. Thanks for watching. I know it wasn't easy, but I know it was worth it. Have a good rest of your day, happy studies, and I'll see you back for your next lecture.